Hello, my name is Husain Borki and I am second year medical student. What's your name?
Murtuza Borki.
Okay. And can I know your age?
50 years.
Okay. Today we are going to do your musculoskeletal exam. So we will be examining your knee, your shoulder, your joints and your hand and your wrist. So does that sound okay?
Okay.
Okay, let's proceed.
Inspect the shoulder and shoulder girdle anteriorly, then the scapula and related muscle posteriorly. Note any swelling, deformity, muscle atrophy, or fasciculation, or abnormal positioning. Look for swelling of the joint capsule anteriorly or a bulge in the subacromial bursa under deltoid muscle. Beginning medially at the sternoclavicular joint, trace the clavicle laterally with your finger. From behind, follow the bony spine of the scapula laterally and upward until it becomes the acromion, the summit of the shoulder. Its upper surface is roughly and slightly convex. Identify the anterior tip of the acromion. Press medially to find the acromioclavicular joint, and then medial and down you will find the bony prominence, the coracoid process. Palpate the greater tubercle and then next palpate the biceps tendon. To examine the subacromial and subdeltoid bursa and the sits muscle, first passively extend the humerus by lifting the elbow posteriorly, which rotates this structure so that they are anterior to the acromion. Palpate carefully over the subacromial and subdeltoid bursa. Now perform the 6 range of motion. First one is flexion.
Now, like this.
Second one is extension.
Okay.
Third is abduction.
Okay. Now, like this.
Then internal rotation.
Okay. Now, like this.
Then adduction.
Okay. Now, like this.
And then external rotation.
Okay, thank you. Leave it around. Okay. Do you feel pain?
No.
Okay.
Press on the scapula to prevent scapular motion with one hand and raise the patient's arm with the other. Flex the patient's shoulder and elbow to 90 degrees with the palm facing down. Then with one hand on the forearm and one on the arm, rotate the arm internally. This compresses the great tuberosity against the supraspinatus tendon and coracoacromial ligament.
Raise your hands. Now hold the position. Raise your arms like this. Rotate your hands. Okay. Now I will push your hands down. You resist my force.
Inspect the patient's hand generally when they are talking or when they are doing something. Inspect the palmar and dorsal surface of the wrist and hand carefully for swelling over the joints or sign of trauma. Note any deformity of the wrist, hand or finger bones as well as any angulation. Observe the contour of the palm, namely the thenar and hypothenar eminences. Note any thickness of the flexor tendon or flexion contractures in the fingers. At the wrist, palpate the distal radius and ulna on the lateral and medial surfaces. Palpate the radial styloid bone and the anatomical snuff box or hollow depression just distal to the radial styloid process. Palpate the 8 carpal bones, then each of the 5 metacarpals and the proximal, middle and distal phalanges. Check the MCP and PIP joint for swellings. Test the sensation by assessing median nerve on the pulp of the index finger and fifth finger, and assess the radial nerve on dorsal web space of the thumb.
Hands up and do like this. Straighten. Like this. Okay. Now do like this. And inwards. And outwards.
Decreased grip strength is a positive test for weakness of the finger flexors or intrinsic muscles of the hand.
Close your fist. Do like this. Do you feel any pain?
No.
Okay. Now resist my thumb. Okay. Do you feel any tingling?
No.
Okay. Now do like this. Now do you feel any tinglings in your fingers?
No.
Okay. Thank you.
Check the alignment and contours of the knees. Observe any atrophy of the quadriceps muscles. Inspect for any loss of the normal hollows around the patella, a sign of swelling in the knee joint and the suprapatellar pouch. Note any other swelling in or around the knee. Pay special attention to any areas of tenderness. Pain is a common complaint in knee problems, and localizing the structure causing pain is important for accurate evaluation. Palpate the medial meniscus, press on the medial soft tissue depression along the upper edge of the tibial plateau with the tibia slightly internally rotated. Place the knee in slight flexion and palpate the lateral meniscus along the lateral joint line. Palpate the medial and lateral joint compartment of the tibiofemoral joint with the knees flexed on the examining table to approximately 90 degrees. Also medially palpate along the joint line and identify the MCL. Lateral to the patellar tendon, move your thumb upward to palpate the lateral femoral condyle and downward to palpate the lateral tibial plateau. Now assess the range of motion of the knee by flexion and extension and internally and externally rotation. Move the synovial fluid from the medial side to the lateral side and then swipe your hand on the lateral side of the knee and see if any bulge comes out on the medial side of the knee. Here the bulge sign is negative or absent. Palpate for fluid ejected into the space next to the patella under your right thumb and index finger. This test helps you to assess extra fluid under patella. After the test, watch for the fluid returning to the suprapatellar pouch. With the patient supine, grasp the heel and flex the knee. Cup your other hand over the knee joint with fingers and thumb along the medial joint line. From the heel, externally rotate the lower leg, then push on the lateral side to apply a valgus stress on the medial side of the joint. At the same time, slowly extend the lower leg in external rotation. The same maneuver with internal rotation of the foot stresses the lateral meniscus. If a click is felt or heard at the joint line during flexion and extension of the knee, or if tenderness is noted along the joint line, further assess the meniscus for a posterior tear. With the patient supine and the knee slightly flexed, move the thigh about 30 degrees laterally to the side of the table. Place one hand against the lateral knee to stabilize the femur and other hand around the medial ankle. Push medially against the knee and pull laterally at the ankle to open the knee joint on the medial side. With the thigh and the knee in the same position, change your position so that you can place one hand against the medial surface of the knee and the other around at the lateral ankle. Push laterally against the knee and pull medially at the ankle to open the knee joint on the lateral side. Cup your hands around the knee with the thumb on your medial and lateral joint line and the fingers on the medial and lateral insertion of the hamstring. Draw the tibia forward and observe if it slides forward from under the femur. Compare the degree of forward movement with that of the opposite knee. Place the knee in 15 degrees of flexion and external rotation. Grasp the distal femur on the lateral side with one hand and the proximal tibia on the medial side with the other. With the thumb of the tibial hand on the joint line, simultaneously pull the tibia forward and the femur back. Estimate the degree of forward excursion. Position the patient and place your hands in the position described for the anterior drawer test. Push the tibia posteriorly and observe the degree of backward movement in the femur.
After examination, record your findings. Okay, so we have completed your musculoskeletal exam. Thank you for cooperating. Thank you, Murtuza.
Thank you.